Thanks for doing this, man. Appreciate it. We're always excited to get you in here. I know it's early morning, early Tuesday morning where you're at, I suppose.
Yeah, not too bad, Sean. It's 9 a.m. Thanks for having me on. I appreciate it.
Oh, yeah, sure. So anyway, I know we had you on about, I don't know, was it 6, 8 months ago? Something that was great conversation. So I want to kind of continue that. I want to just, I'm not going to go over their introductions. You're a gastroenterologist from Australia that is at least favorable to eating meat, not necessarily fully carnivore, but, where there's a lot of misconception, I think, around what meat does to the gut, some of the other things out there, and perhaps you can shed some of your insight. But I want to just, I was just, scanning through my social media, and you just put up a post about, different macronutrients and their effect on blood glucose, which I think is a fair comment. And I think that's a good thing. I know you've probably been influenced by Ted Naiman, and, his sort of take that protein is important. And, I can say that I've always been supportive of protein, if anyone has been. I mean, I think, when we're eating meat, we're going on a relatively high protein diet for most people. But one thing I want to, I just want to dig down deeper in this, because there is still some controversy here. We see some people particularly with diabetics, if they eat sort of too much protein, perhaps, and too much is always is a kind of a tautological term, but there's a threshold of protein that they eat where they do see problems with blood glucose. And then conversely, one of the things that I've seen, clinically here within this community, and I'll reference back to the world of the work of, Louis Newberg, perhaps you're familiar with him from the 1920s, and diabetes. And, what he did was he took people on very high fat diets, 90%. And, he consistently got their blood glucose very low and consistently maintained that over a period of time. Now, the caveat to that, the kicker was they were also very low protein. And I think, when we talk about it, I think the way I think of fat is it just kind of smears the curve over one to the right. It prolongs the duration of rise. So you might have and we know that it slows down the digestion of foods. If you're eating a bunch of carbohydrates with fat, you're going to have maybe not quite as high as a rise, but it's going to go for a lot longer. And the cumulative effect in the area under the curve might ultimately be higher. But I think, and maybe you've seen some other work on that. I've not seen any studies looking at someone eating just all fat. I'm saying that what happens with that, it's usually in the context of a mixed diet. When you add fat into either protein or carbohydrates, you see that prolongation and perhaps extension of that glucose effect. And so the one thing I've seen, because I can tell you a number of people here, and I'm not saying it's best for body composition, because I did that experiment and I found that I lost weight, got skinnier, lost muscle, by eating mostly fat and not enough protein. So I think there's a caveat there. But what I see is, we've got some people that they're eating, 250 grams of fat per day and maybe 40 grams of protein, and they're consistently seeing blood glucoses in the 50s and 60s and even 40s for a prolonged period of time. And so I think, one of those things I see with that graph is I'm just wondering, because we say long period of time, 6 months down the road, if your body composition is worse, are you ultimately doing yourself harm? And so speak to that a little bit. I mean, because like I said, I'm very protein centric, very protein friendly. I think protein is way undervalued in Western society. As you know, the protein intake average is about 15%, which I think is half what it should be, or perhaps even less than half what it should be. So what are your thoughts around that these days?
Great points, Sean. I mean, you've done a lot more for protein than most, and I've always been very supportive of your philosophy, because you are doing that. I think the point I made in my latest post was that essentially protein is king. Just to speak on a few points, you've mentioned there that the protein intake in the average American is about 15%, which is abysmally low, and vast majority of their protein actually comes from plant-based protein, which, as we know, is incomplete. What's interesting to note is even creatures such as the chimps, their animal-based protein consumption is about 6 to 10%, which is almost on par with the average American, and that's a sad reality. We are built for much more than that. With regards to the points that you've made with regards to fat, I think, for me, it's always, well, if protein's king and we've got these two fuel sources in fat and carbohydrate, it is just so much easier to consume fatty proteins because they're not mixing fuels. It's a sense of convenience. Additionally, fat is an essential macronutrient, as we know. It can be very vitamin rich. So I'm very favourable to the diet that you consume. I'm very supportive of it. Where I think it can be lost in translation, especially in some of the ketogenic circles, where this overconsumption of fat occurs with the intention to stabilize blood sugars. I think that is, and we've seen that in clinical practice, and we work very closely with dietitians. Fundamentally, that is a lost cause, because yes, in someone with very, very good muscle quality, I guess that's going to soak up a lot of that fat-based fuel, and it all comes down to muscle-based quality. But in someone with very poor muscle quality or is sarcopenic, I think that might be problematic, because that fat has to accumulate. It has to go somewhere. If I tend to think of muscle as a sponge, and if you've got a saturated sponge, well, it has to store, and I think visceral fat is where it accumulates. So this is the issue. I think it needs to be weighed up. I think those that are younger with greater muscle quality, they can get away with it. But as you've seen in the experiment you performed, and I watched that with interest, the loss of muscle, and especially those that are active and utilizing it, is significant. So I think fundamentally, if protein deprivation is occurring, well, it has to come at the expense of your own muscle, one's own muscle as well as their bone. I think people will draw on those reservoirs.
Yeah, I don't disagree with any of that. I think it is, and one of the things, we saw, I think, with the ketogenic diet, people saw differences in satiety. We can talk about, the relative value of satiety. It's nice to say you're going to eat less calories, but how do you get there if you're hungry all the time? It doesn't work. So you find a satiating food. And then we had this period of time where people were just pounding in, all this basically concentrated artificial fats.
Yes.
We see that, and we see the one thing that, with Ted's diet is that, this PE diet, I can see where you can make that diet just protein bars, and I think you get into trouble, because I think anytime you get, when we talk about macronutrients, that's not how food is designed to be consumed. It's designed to be consumed as a whole food product. Historically and evolutionarily, and I've seen a lot of people that have been, this bodybuilding diet has been around forever. It's lean, skinless chicken breast, some broccoli, and maybe a little bit of rice, and I did that 30 years ago. Hell, when I was first lifting. So it's been around forever. But what I consistently see is a lot of people with gut problems due to that, and maybe it's from overconsumption of, these processed proteins, maybe it's the whey proteins or whatnot. I mean, I had a nice conversation with a guy named Gabor Adrossi, and we talked about incretins, and we talked about, certainly around refined grains in the way, we weren't designed to really eat powder. I mean, you think about it, our teeth don't make powder out of anything. I mean, you'd have to sit there and chew for, a week to get a powder, a true powder like we can do with a machine. So when we do that, and even with protein powder, I mean, we kind of bypass the sequential, the temporal, I guess, relationship between these incretins and other hormones. Do you find any problem with, just limiting it to say, eat 40% of your calories from protein, the rest can be fat and carbs. It doesn't matter where it comes from. I mean, this again goes to I'd say, eat plenty of protein and make sure it comes from whole food sources. And I think that's all the only clarification you need to make in my mind. And if you want to go carnivore, that's great too. But what are your thoughts around these processed proteins? Because I think everybody's rallying around, hey, don't eat processed carbohydrates. We know we don't need to eat Twinkies and Doritos and chips and all that crap. But there is this, a lot of people are eating these protein isolates, whether it comes in the form of a candy bar, quote unquote protein bar, or a powdered drink. What are your thoughts on that?
Great points, Shawn. I mean, just to take it back a step further, with regards to Ted Naiman's diet, I see where Ted's coming from, but I'm not fully in agreement with a lot of his philosophies. I think the point you made is very important. I think processed fat, in the sense of liquid calories from oil or butter and things, these sort of things are very, very easy to overeat because there's no satiety aspect associated with it. And that's the same with the fat bombs and in some of these low carbohydrate groups. Whereas animal fat, in association with protein, is very difficult to overeat because there's consistency to it. You have to bite through it. You've got to chew through it. There's many aspects to it. Processed protein in whey powders and so forth, I tend to see a lot of, as patients, a lot of personal trainers and bodybuilders with a lot of gut-based symptoms. And I think people fail to take into consideration that you will overwhelm the capacity of the small bowel to absorb this protein sometimes if it's in this sort of liquid form, especially whey protein or plant-based protein as well. So if that's the case, a lot of that protein ends up in the colon putrefying, and you sort of select for a very putrefactive type microbiome, which then you've got the issues with these nitrogen and hydrogen and methane and all these sort of gases being liberated from these microorganisms. So yes, I mean, protein can be overdone, and often overdone when it's in this sort of protein powdered format. I've never been supportive of it. I think if you're an elderly person trying to get in protein and you've got to suffer with poor dentition and so forth, yes, perhaps it's not a bad idea to introduce whey-based protein to it. But I do wonder how much of this protein we actually absorb. Some of this small, how much we're overwhelming the small bowel capacity. So yeah, no, I agree. I think processed foods, processed proteins, no good. And additionally, from a satiety perspective, well, there is no satiety. You know what I mean? So yeah, that's all really good points.
Yeah, I mean, back in the day when I used to eat protein powders, you know, when I was 20s, 30s, whatever, one scoop was 25 grams. I'll put 3-4 in there, 100 grams in one setting. And and again, there was almost no satiety at all. I mean, I know there's studies out there looking at eating patterns after protein, but I mean, I think you can eat a hell of a lot of that, and you can quickly do that. And I just wonder what is the capacity. And I'm sure it varies from person to person, but there's got to be a point where you overwhelm the absorptive capacity, you know, and it just kind of like you said, it gets pushed on down to the colon. We see that with fat all the time. You know, we see people overconsume fat and they have steatorrhea. So they're wondering why their stools are floating, and because they can't absorb that. So the same thing's happening with protein. Let's talk about fiber a little bit. You know, obviously I think fiber is one of those things where it's plus minus. It may help you, it may not. You know, it's not essential in my view. There's a lot of people that really push back on that. There is, you know, I just, you know, one of the arguments is about butyrate. It goes around these short chain fatty acids, you know, and butyrate being the primary one that people think is important for gut health. I literally just saw somebody who had, you know, a fecal short chain fatty acid test done that was on a carnivore diet. Their butyrate levels were completely normal, within the normal range. And so what do you think's going on with fiber? Can we get butyrate without fiber? Do we have to have it in our diet? Are we going to get some awful outcome without fiber in our diet?
Sean's really interesting point. I mean, the data that I've seen to date, and all of this is very, very, it's not common knowledge, but we as humans, the amount of fuel that we're supposed to extract from short chain fatty acids fermented in our gut from things like non-absorbable carbohydrates and fiber is only 5 to 7%. Right. And so where does the rest of the 93 to 95% of the fuel come from? I think, and this is part of the issue with this food pyramid. It's pushed fiber as almost as a nutrient source when it clearly isn't. It's simply a substrate for bacteria, and the bacteria benefit from that. I mean, they ferment this fiber and extract these short chain fatty acids, but the kicker is that they utilize most of it and give us a little bit. So it's a partial bargain with the microbiome when it comes to fiber. And so from a perspective of the human gut, we very, very quickly overwhelm our ability to hold this gas in very good, you know, with excessive levels of fiber. And this is the issue. A lot of people get very, very uncomfortable with excessive fiber consumption because of all these issues being carried in the bulk and the fermentation that goes with it. With regards to butyrate, generated on a zero fiber diet, I think very quickly, and I think we made this point before, you can tap into your own fat stores and pull beta hydroxybutyrate, which is a far more efficient molecule to and you nourish your colon systemically through the blood supply rather than locally by fermenting it within the cecum. This is why a lot of people on very low fiber diets, actually a lot of their bowel issues alleviated as long as they're getting the right macronutrient ratio to ensure that their beta hydroxybutyrate levels are elevated. Now, on a high protein diet, because of the fact that you're relatively calorie restricted due to the satiety factors, you are going to be tapping into your fat stores at many points during the day.
Yeah, I'm just going to bring it back because you were talking about, different gases being elicited, methanes and sulfide gases and whatnot. I've seen you've put up some studies looking at that and the relationship between methane and various ill health, gut health issues. What is the relationship? I know we talked about the fact that maybe even reflux is related to kind of back pressure from gas being produced distally. What have you sort of further elucidated about this stuff?
It's quite fascinating, Sean. I mean, and I'm glad you actually listened to or look at some of these studies that I put up. Thank you for that. Methane is a potent mediator in slowing gut motility, and people forget from the mouth to the anal canal, it's fundamentally a 6 meter long tube. There's various offshoots and so forth, but the thing is one long tube, and if there is significant amounts of methane in the hind gut being generated in the hind gut, the entire gut slows down, including esophageal contractions, which is fascinating, right? And so a lot of gastroesophageal reflux can actually be mediated downstream in the colon. There have been a lot of studies that have shown this, quite elegant studies as well, so where they've infused basal methane into the colon via an external tube and then noted that esophageal motility slows down. So I think methane is an issue, because if you've over time selected for methogenic bacteria, right, in your hind gut, and you're predisposed to then creating excess amounts of methane from fermenting carbohydrates and other fibers and not starchy type of foods, you're essentially going to end up with issues related to gut motility, and gut motility is something that's kind of under looked at, because we look at reflux as acid-based disease, but really at its core, I think it's a motility-based disease related to muscle.
Yeah, there's one of our members here is asking about red meat and meat and cancer, and typically red meat and cancer. One of our members was discussing or wanted to question about red meat and cancer, and I just, one of the things that I know you've seen, it's very low, relative risk epidemiology is basically what that's sort of basically founded on. But can you speak to some of these mechanistic things? We talk about, you mentioned a putregenic, fermentation system from protein. I mean, one of the things that's interesting, I've seen studies looking at soy versus beef protein. Soy protein is actually less well absorbed, probably due to the trypsin inhibitors. So you actually get more soy protein that goes into the distal gut than you do sort of beef protein. But I mean, there's, TMAO, there's N-nitroso compounds, there's heme iron, there's, saturated fat, all kinds of mechanistic proposals, and then of course these high heat cooking compounds, PCAs and the other hydrocyclic amines and so on and so forth. What are your thoughts on meat causing cancer?
I tend to take a very basic approach to things, Sean. I actually, yesterday I was doing a colonoscopy list, and I turned around and said to the nursing staff when we got around to the right side of the colon on a patient whose preparation wasn't ideal, I said, do you see all this plant material? There was nuts, there was seeds, there were leaves. I asked them, do you see any beef or do you see any meat in here? And the answer is you never see that, okay? But the reason the reason for that is because we, as humans, we're autoenzyme digesters. We have this concept that meat rots in the gut, but that's very, very far from reality. We use stomach acid firstly to cleave meat into smaller portions to expose protein absorbing areas, and then we utilize the brush border and enzymes in the small gut to actually break it down very, very efficiently. So the interesting thing is very little animal sourced foods actually makes it into the colon. So it's interesting to me that a lot of people in the plant-based community suggest that red meat rots in the gut and causes cancer. The mechanism is very, very far from that. I think if we had a step back, Shawn, there is no doubt that what is correlated with colorectal cancer is actually obesity and metabolic syndrome. So really the diet that allows you to be metabolically healthy and metabolically flexible is very unlikely to be associated with colorectal cancer. You've made the point about the weak epidemiology that we've got linking it, and I don't need to revisit that because I think that's well known now that these were really founded on basic epidemiological studies which have significant flaws, and you know, it was a really poor quality statement by the World Health Organization, and hopefully something that we can readdress. But for the moment, it is still pushed out as by our health bodies that red meat is a risk factor for cancer and that it increases risk by 18%. Yet we know that the World Health Organization, when they looked at these studies, that 18% was for processed meat. Now, somehow that's been extrapolated to also include red meat in general. So really, they haven't separated from processed meats, which tend to be found in burgers and pizzas and so forth. And you know, they haven't been able to separate it from good quality meat, which is what most in this community tend to eat. So, but to sort of end this point, Shawn, it would be, well, how can a diet that makes you metabolically healthy increase your risk of colorectal cancer, right? It just simply doesn't make sense from a logical perspective. With regards to TMAO and the heterocyclic amines and so forth, I think again we're overcomplicating things. I mean, we've utilized fire for 2 million years, 1.8 million years, and we've always cooked our meat, and in fact that whole concept of cooking was critical to our brain development because it allowed these nutrients to be accessed easier. It was a critical part of our evolutionary history. So I think we're overcomplicating it. The human body is very, very capable of dealing with a lot of these compounds, especially with a gut that is extremely permeable. So I think we have to simplify the approach. I would say that the evidence that shows red meat causes cancer is extremely problematic, flawed, and it needs to be questioned.
Yeah, I mean, that was the 2019 Nutrex large systematic review found the same sort of thing. It said the evidence is extremely weak at best. One thing that I thought was interesting, I had a discussion around TMAO, and it's been often linked to various problems, whether it's heart disease or some people even link it to cancer, is that TMAO accumulation seems to be associated not with, you know, meat by itself. You know, obviously fish is high in that, but it seems to occur when you have a dysbiotic gut. And so if your gut is compromised, then that's a situation where you can elicit these compounds that may be problematic. But if you have a gut that is sort of normally functioning, then these things shouldn't be a problem. Do you find that there's a way, you think that gut dysbiosis can modulate our risks in some ways?
Absolutely, Shawn. I think gut dysbiosis is at the key to modern illness, and it's kind of this vicious cycle that we enter into. The issue at the moment is that we've got a huge proportion of the population on proton pump inhibitors, and I worry about how this might all start actually within the stomach. In addition, we're consuming foods that are essentially poor quality, processed, and have to end up in the colon fermenting. So a lot of the times, just by virtue of the way we're eating, very low percentage of animal sourced foods, essentially bypassing the small bowel and utilizing the colon a lot, I think we're just selecting in our hind gut for a lot of strange species of bacteria, which I don't think the human gut is particularly adapted to. Plant-based protein, you've mentioned this before, interestingly, is more prone to putrefactive digestion because of the anti-nutrients within these plant-based proteins. That's found in soy and a variety of other plant proteins like maize and a lot of these cereal-based compounds. So it kind of speaks to the point that the more reliant a nation is on plant-based protein, interestingly, the higher their rates of stunting, the higher their rates of diabetes and so forth, because fundamentally these proteins are not well absorbed, hence cannot be incorporated into muscle and bone like we need them to.
You mentioned, doing a colonoscopy and, seeing, and I've had this confirmed for people with, ileostomies. They say when they eat meat, there's nothing that comes into their ileostomy bag, maybe a tiny amount of liquid. Anytime they eat fiber-rich plants, none of it basically gets digested. They have a huge bag full of stuff they have to change. And so, one of the other thoughts is that diverticulitis is quote unquote associated with red meat consumption. Therefore, if you have diverticulitis, you're told to cut back on meat or red meat. I've had pathologists tell me when they've done, sections through diverticula, they often will see a seed or a plant fiber or stuff like that. What are your thoughts on diverticulitis? What's causing that? Do we know what's actually causing that? Is it overpressure? Is it a failure of the musculature, a neuromuscular issue? And then why do you think people get diverticulitis and diverticulosis?
Great question, Sean. I think the latest data that I've looked at, some of the more scientific-based studies that was looking at mechanistic basis for diverticulosis, it seems to suggest that a lot of it is increased intracolonic pressure, which is very interesting to me because increased intracolonic pressure can only come from in the setting of excessive plant-based consumption, really, because you're essentially increasing stool bulk through all this fiber, whether it be soluble or insoluble. In addition, a lot of it's to do with gas, colonic gas, and that's a very prevalent problem, I think, in this modern world. I think we're utilizing the colon excessively, whereas as a species, we are mid-gut absorbers. We are built with a very, very acidic stomach, and we use our mid-gut for absorption, yet paradoxically, we're using our hindgut. And we cannot do that efficiently. Anatomically, we are definitely we definitely disadvantaged from that perspective. But then, on the flip side, that's what helped us build our brain. And so we've got this paradox there. So with regards to diverticulosis, that's an absolute pandemic. Just in my career as a gastroenterologist over this last 10 years, we're seeing it in younger and younger and younger patients. And to be honest, the vast majority of colonoscopies that I do, I see diverticulosis. Is fiber protective in diverticulosis? The data is very, very scant there. And a lot of that is, I think, just mantra that's been repeated over the years. I see diverticulosis in people that are on extremely high fiber diets. And interestingly, some of it tends to be worse in those groups. So I think it goes back to potentially overuse of the large bowel. In addition, an element of energy starvation of the large bowel. Obviously, there's some genetic factors as well associated with it.
I don't know if you're familiar with this study. I referenced it on many, many occasions. I think it was Ian Peary was a primary author on this, and this was a series of 2,000 colonoscopies. I can't remember what journal it was published in. It was around 2012, and they basically stratified people in high to low fiber, and they found the highest fiber groups had the highest, occurrence of diverticulosis. And so I thought that was, kind of an interesting study to see that they kind of went against the, like I said, the sort of the talking points that we just continue to eat more fiber. We see that, well, let me ask you about your practice now. Obviously you've had probably a change in direction and thought process since you started your medical career, just like I had. And are you able to use some of these principles that you're learning? And if so, how often are you successful in, one, getting the patients to actually be adherent to this, and then two, what are the outcomes, assuming that some of them are?
Thanks, Sean. Look, this is, in the last few years of practice, probably been my happiest, because I feel like I'm implementing changes that help people on a very fundamental level. The issue is, Sean, the vast majority of people won't take on the advice. It's very interesting to see that. We find that the older the person, and this is a generalization, the older the person, that the less able they are to be malleable or flexible about these changes. In addition, a lot of what we speak is so anti-establishment, I guess, the best way I can put it, that I find it very, very difficult to implement change in some of these people. We're essentially going against a food pyramid that they've been indoctrinated with for many decades, and still seeing headlines coming out talking about the dangers of red meat and the dangers of animal sourced food, which confuses people fundamentally. But the way I've been able to do it in my practice, Shawn, I work with 4 brilliant dietitians now. They're all low carbohydrate dietitians. We talk a lot about personalized nutrition, right? To these patients, we don't put a label on the diet, but worked into that paradigm is the fact that we prioritize protein for these people, in particular quality protein, which is animal sourced. So we maximize protein, and then we teach people that fat actually is an essential macronutrient. And we work into their mind that potentially carbohydrates are non-essential, and so we personalize these diets for people. We are very we see a diverse range of people, from people that are extremely fit and personal trainers to those that potentially coming from a vegetarian spectrum. But we try and make it work, and it's not always easy. And I think the multidisciplinary team approach has been the best approach. I'd love to work in the future potentially with an exercise physiologist and groups of trainers and so forth, but I think that's for the future. But to answer your question, Shawn, I'm probably happiest practicing this way, as opposed to the times I was writing scripts to treat people's reflux with anti-acid drugs.
Yeah, I mean, the point about the exercise physiologists, or the people that are going to get people exercising, I think this is something that I think a lot of people, it gets lost in these diet wars. That regardless of what nutritional plan you get on, you need to be doing resistance training, in my view. I mean, this is what's going to give you preserve lean muscle mass, regardless of anything else, because you can look at proponents of any diet, and the ones that work out are going to have more muscle mass. It may be one may facilitate it more than others, but that has to be part of the equation, in my view. That's what I think. And I've been doing this stuff for 4 decades now. So I mean, it's kind of just like breathing for me, that type of thing. And just correct me if I'm wrong, but I'm just looking at some of your recent posts. You look like you personally put on some muscle. Am I imagining that, or is that something that I'm legitimately seeing?
No, absolutely, Shawn. You've been very, very inspirational for guys like myself, and to do what you're doing in your 50s. I'm entering my 40s now, but it's been phenomenal to see. And I have put on muscle. You can't help but put on muscle with a diet that's rich in quality protein. In addition, what it's allowed me to do, Shawn, is that I have a desire to move. Do you know what I mean? I've got a desire to get out there and exercise. I've just got endless energy. Whereas I think if you're affected with poor energy because you're eating heavily processed crap all day, it's just very difficult to motivate yourself to get out there and exercise. Our body is built for movement, and I've come to appreciate this on a diet that prioritizes protein the way we do. So I think exercise is key, and I think movement is key. You can still get overweight and insulin resistant on a diet that is extremely rich in protein. So you've got to get out there and move. And we encourage this very, very strongly with our patients, even our elderly ones, that resistance training is critical. We're built for that.
Yeah, I mean, there's studies out there showing 80-year-olds can put on muscle, so there's no age excuse. I think we had the discussion in the past about probiotics and kind of feeling that they may not be that helpful, and perhaps they're kind of a waste. But thoughts on you mentioned proton pump inhibitors. We have so many people that are on Prilosec or omeprazole, and they shut down their stomach acid production, hoping to prevent the reflux, and maybe they do that, but at the peril of not being able to digest anything anymore. So it's kind of a problem. And when we see this chronic under secretion or high pH, is there anything we can do? Does that come back? Do we have the capacity to regain? We see, stomach acid production being a problem as we age. Is there a way to reverse that perhaps? And then as a counter to that, or as a addition to that, some people often take, hydrochloric acid supplements or lipases or things. Thoughts on the supplements, and then the inherent condition of the body to sort of recover from these conditions, this chronic acid suppression.
Yeah, it's an interesting one, Shawn. I think the first steps to getting off the proton pump inhibitors, proton pump inhibitors don't treat the reflux. They basically reduce the acidity of the refluxate. You're still reflux. It's not as acidic, hence not as irritating. It doesn't fix the fundamental problem, which is an issue related to motility and also diaphragmatic weakness, which then leads to things like hydersemia. The diaphragm is this really important muscle that pinches around your stomach and maintains it. But we've got this diaphragmatic sarcopenia in the modern world, that second valve that pinches around the stomach's lost. So I think the key step is to get off the proton pump inhibitors. It's actually not that difficult to do. I think once you start dropping a little bit of visceral fat and reducing the foods that ferment, the reflux actually improves relatively quickly. So once the proton pump inhibition is stopped, once the channel blockade is stopped from that drug, the acid secretion does improve. But you're absolutely spot on with regards to acid production reducing in the elderly. That's unfortunately an inevitable process of aging. With regards to the hydrochloric acid supplements, the data is very mixed on it. Shawn, I personally haven't used it. I do my best to get people off proton pump inhibition. I've found that to be sufficient for most. With regards to pancreatic supplementation, there's a lot of data for that. If you've got pancreatic insufficiencies, I think the lipases are very, very efficient. You can have pancreatic insufficiency in a variety of disease states. It can be easily measured. I think some people are utilizing these pancreatic lipases without indication. But you can do a fecal test to check if you've got pancreatic malabsorption, and it generally happens in disease states where the pancreas is compromised. Usually we see it in people that have consumed a lot of alcohol over the years.
Yeah, I'm just gonna nuance push back on one statement about inevitable loss of gastric acid production as we age. I don't know that that's, I think it's extreme. I think it's one of these common and perceived as normal type of thing. And I don't know, maybe my acid production has gone down, but I can throw down 6 pounds of meat as a nearly 55-year-old guy with no problem at all. So I do think there's some degree of that is maybe that's just a sequela of, chronic disease, whether it's metabolic disease, it becomes so overwhelmingly prevalent as we age that, it's just like anything else. Arthritis is common in old people, but so is every other disease. And maybe it's not the norm or what we're designed. I don't know. It'd be interesting to see a study on healthy old people that aren't, also, suffering from metabolic syndrome and what their rates of acid suppression. Maybe if there's some data on that. I don't know.
Well, Shawn, it's a good point. Look, I look at aging as essentially oxidative stress over the years. We are all prone to oxidative stress, and we must inevitably age. We can't live forever. But you're absolutely right. Like if you're on a diet and on an exercise regime that minimizes oxidative stress, and we can measure this, things like high sensitivity CRPs, LDL subfractions to see if your LDL is an oxidative particle. We tend to see people on these low carbohydrate, high protein, moderate fat diets tend to have very little oxidative stress, most of them, right? And it's very reduced levels of oxidative stress. So if you're not generating these free radicals, then you're preserving a lot of these cells a lot better, whether that's gastric acid producing cells or your colonocytes. I think it's like anything else. If you're utilizing your stomach acid and there's a reduction of these reactive oxidation species, you're going to preserve it a lot longer. So no, I agree with what you've said. It's just for most people in this modern world, they exist in this really highly oxidative state where the damage is coming from within based on their diet.
Yeah, and it may be a difference between, you develop, maybe you develop it at 90 years old rather than 40 years old, like
Yeah,
everything else.
yeah,
We're seeing evidence of dementia in late 30s and early 40s now, which is
yeah.
really, really troubling to think. Let me ask you about, and I'd be remiss not to at least mention this. I know we've talked about this before, but the inflammatory bowel diseases, Crohn's and ulcerative colitis primarily. What is now your protocol for dealing with that, either medically or dietary or lifestyle intervention wise? I mean, I'm sure you still see a fair bit of that. And how do you handle it? And what have you noticed with that?
Inflammatory bowel disease is fascinating, Sean. I personal experience that I've been seeing is with mild to moderate ulcerative colitis, the response to lifestyle change can be quite rapid, actually. But again, the patient has to be motivated and willing to take on the diet. We tend to start with and the dietitians do this within our practice. We start with an exclusion protocol, which eliminates a lot of high toxicity foods, in particular high toxicity vegetables, from the diet. We essentially strip it down to bare essentials, which is fundamentally quality animal protein. In some people, we found that eggs can be immunogenic, and we tend to do these food print tests, which look at the levels of immunoglobulin in the serum. I'm not sure how valid they are, but we found it useful. Additionally, we found dairy can be an immunogenic trigger for some. So we tend to eliminate these foods and just strip it down to bare basics and then add back in foods. I don't think people necessarily need to be, and we've seen this in clinical practice, that strictly meat-based, but it's about repairing the gut, repairing the colon, and then adding in low toxicity fruits and vegetables for sanitary reasons. I think it's up to the individual, but some simply can't pull off from a long-term adherent perspective a 100% meat-based diet forever. So that's been my experience. Crohn's disease, I suspect, is much more complex. The dietary approach to Crohn's disease has been variable. Perhaps that's related to compliance as well. With regards to very, very severe inflammatory bowel disease, Sean, I've got to be careful instituting diet just from a regulatory standpoint. So we tend to offer them medical-based management first, but with an option to potentially later on, once they're settled, look at changing lifestyle. And I work with a team of guys. One of the gastroenterologists within my practice, he's an expert on some of these biologic drugs, and we tend to employ them for people that are quite severe to get on top of the inflammation early rather than letting the inflammation kick in, and it becomes a vicious cycle sometimes in these severe IBD patients.
Yeah, I think that's fair assessment. I mean, like I said, you've got people that's severe. I mean, they really run risk for perforations and setting up chronic fistulas and all these horrible things that you never want to have to deal with. And so if you got something that can, immediately improve that, and then you go from for the long term, you look at maybe a lifestyle change. It's interesting, and this is a thing I've seen, the same thing with dairy and eggs. Some people it's a problem, some people it doesn't seem to be. For me, and it seems to change over a period of time as well, which is kind of interesting. I know there's a period of time where I didn't do as well with eggs, and now I can eat a dozen and no problem at all. In fact, I had 6 about an hour ago, and so I'm totally fine with that. So, so in Australia, I'm aware of, at least, Gary Fettke was over there. He got in trouble with regulators because he told diabetics to cut back on the sugar, which you think would be an innocuous statement. Is there any pressure for you to toe the line dietarily, that you must recommend this and that, or if so, your registration or your license is it in jeopardy?
Not so much. I mean, I think what came out of Gary's case was that there are certain doctors that should be allowed to give dietary advice, and gastroenterologists and endocrinologists, as well as general practitioners, were some of them. I think every doctor should be allowed to give dietary advice as long as what's being provided is valid. I still think we practice in a very regulated environment, Shawn, and I'm glad for that. I think we need regulations to be able to allow practitioners to have a standard of practice. However, diet is a very, very, very contentious issue. Shawn, I've made the point before, diet's like the new religion, right? And so we've got all these factions developing, and it's worrying, Shawn, because I've had to deal with a few complaints actually with regards to people taking offence to the dietary advice that I've given, which is interesting because the fact that they're seeing a gastroenterologist suggests that there are gut issues potentially related to their diet. So you try and correct all of this, but we do get pushback. And if there are complaints, then we've got to respond to the complaints. So it's it can be a bit of a nightmare situation. And we've got very, very strong regulatory bodies, as Gary saw over the years. But what's been a saviour for me is the fact that I work with accredited dietitians. So I tend not to delve into the personalised nutrition that they require. It's more I approach it from a broad sense of, well, animal source foods are important, quality protein is important, and then we let the dietitians work out the personalised nutrition. So that's been a saviour for me. I'm very grateful for the team that I've built around me to allow me to institute this way of practicing.
Yeah, one of the things that I often get people that have been to the physician, and sometimes gastroenterologists, and with Crohn's and ulcerative colitis, and they will be told by their gastroenterologist, hey, diet has nothing to do with your condition, which to me, I mean, of all potential conditions, I mean, the digestive system would be, you'd assume would be, the front line affected by diet. But do you see that many people within the gastroenterology community are still sort of the belief that diet has very little to do with some of these disease processes?
It's an unbelievable statement, isn't it? That diet has nothing to do with the inflammatory bowel disease. What a cop out from our industry. The sad reality is there's just not enough data because, I mean, where's the money in performing dietary interventions, right? So, but I think diet has everything to do with chronic illness in general, full stop. And I think inflammatory bowel disease, most of all, there has to be a dietary trigger. Of course, I acknowledge there's other factors, childhood antibiotic use, the microbiome that you inherit from our mothers, all of that comes into play. And there's no doubt as a species, our microbiome through every generation is just getting worse. It's becoming less resilient, more pathogenic bacteria. But at its core, I think it's very dynamic. It's still able to change, but it requires you to fight against this processed environment or processed food environment that we exist in, which is an uphill struggle. I think that statement that is thrown around that diet has nothing to do with inflammatory bowel disease, it's simply lazy. It's what we're taught in medical school, Shawn, and I think they're just regurgitating it, not open to new ideas, very drug-centric. And I think that needs to change. And to go back to the point you made on resistance training, we know that even resistance training or exercise changes your microbiome. So all of these factors needs to be taken into consideration and delivered to the patient as a package. And it's really up to them whether they open that package and run with it, right? But we've got to be able to deliver it all.
Yeah, what is, one of the things that, there's a statement about, you can only absorb so many grams of protein in one setting. I think that's been misconstrued. You can only convert so many grams of protein to muscle protein synthesis at a particular bolus, but our gut is very, has a high turnover rate. Correct me if I'm wrong. So, it's an interface with the external environment. And is our gut turning over pretty rapidly? Typically, does it change pretty quickly? Is it, new cells being replaced? Do you know what the gut turnover time is?
Yeah, it's rapid, Shawn. So the vast majority of stool bulk is actually our intestinal cells just sloughing off. That's what stool bulk is, which is very, very interesting. And I think there's a lot of misconceptions out there about our gut can only handle a certain amount of protein load and so forth. I think if it's a processed protein, yes, because it just rushes through this rapid transit into the colon. Once it's in the colon, there's no point. You've got no ability to absorb that protein. It's all up to the bacteria now. And they essentially strip that fuel for themselves. They give you very little in terms of that bargain, as we've discussed earlier. But we've got this reservoir, we've got this capacity to contain things like meat within our stomach and slowly release it into the small bowel. The body regulates that so well and so efficiently. And I think we failed to take that into consideration, that this system, this digestive tract that we've evolved from a fruit-eating ancestor 4 million years ago to where we are now, is finely tuned for animal-sourced foods. It really is. And this is the problem. Evolutionary biology is not something that's taught in med school, is it? It's not a big part of our curriculum. It makes zero part of our curriculum. So we fail to understand these nuances as doctors, and hence we can't really hand out that knowledge to our patients. But the way I try and teach my patients is we are very, very finely tuned for it. It's just the modern environment, the modern method of eating is just completely out of keeping with evolution, and we have evolutionary mismatch. So in terms to go back to your question about meat, I think we've got great capacity to absorb it. We've just got to eat to satiety, and intuitive eating and that type of approach to dieting is the way to do it, I think, long term.
Yeah, there's a question about colonic polyps, and I'm sure you've seen plenty of them over the years. Is there a relationship between that? And I look at, these sort of, lipomas or these sort of neoplasms, these neoplastic neoplasm, or these non-malignant neoplasms, whether it's lipomas or skin tags, acrocordomas or whatever, as maybe related to insulin problems. I mean, insulin is obviously something that allows things to grow. Do you find a relationship between polyps and obesity, insulin resistance, hyperinsulinemia? Is that something you see?
Zero doubt, Shawn. You can almost pick the individuals that will have colonic polyps. They're overweight generally diabetic. Being Caucasian is also a risk factor, and being above the age of 50. These are all risk factors for colonic polyps. I think it's been linked to red meat before, but the randomized control trials like the polyp study and the Women's Health Initiative, which is a high quality study, really didn't show that a high fiber diet or a vegetable plant-based diet helped in terms of polyp development. There really wasn't. So it all goes back to hyperinsulinemia, which is of course linked with diabetes and obesity. I think that is the biggest risk factor. Insulin at its core is a growth factor. You could use it to grow your adipocytes, or you could grow your muscles. I mean, bodybuilders utilize their own endogenous insulin to grow. It's just they've got to eat in a way to stimulate that. We've got to remember that it is a growth factor, and I think you've answered the question there, Shawn. It is hyperinsulinemia that's the issue at its core. That's a risk factor for these colonic polyps, and we're seeing more and more of these now.
Do you have any sort of aspirations to do any kind of research or do any sort of that stuff? Because I mean, I just wonder. I know it's a pain in the butt. I mean, literally. I mean, just to do that stuff is a lot of extra work, and a lot of people are too busy with their practice to do that. But I'm just wondering, I know at one point when I was doing orthopedics, I was looking at people that had various orthopedic presentations, and I was looking at one, carpal tunnel syndrome. I just, pressure. Sometimes pressure means growth, swelling. I thought, well, let's do an insulin level on these people, and I started seeing high levels of insulin. And I don't know, obviously it was a relationship, whether it was causative or not, or it was just something that's so common that we can't exclude it. But do you have any interest in sort of a research side of things? Is that something that's on the menu at some point, perhaps?
I think so, Shawn. At the moment, as you said, the practice is just overwhelming. It's just so busy, and I'm a father of young kids, 3 of them under 7. So, just keeping my head above water at the moment. But in terms of the wealth of data that we're accumulating just in private practice, is ridiculous. And our lead dietitian, Jessica Turton, she's a PhD on low carbohydrate diet, actually spoke at the American Diabetes Association talk in 2020, just last year. She's a very strong academic. So we're collating all this data. The beauty of it is the data is mixed for everything from irritable bowel syndrome to inflammatory bowel disease to diabetes. And at some point, we've got to sit down and actually put it all together and publish something. I'd love to be able to do it. It's just finding the time. Additionally, here in Australia, there's a lot of red tape around research, and unless you're affiliated with a academic centre and an active professor and so forth, it can be very difficult to have your research be seen as legitimate, and that is the other issue, So I'm fascinated with data, love it, but getting it out there will be the issue. I'm very interested to see what you do with your trial in the future.
Yeah, no, we've talked, privately on this stuff. Yeah. And so we're still obviously in the fundraising phase, but yeah, we've got a lot of potential for some interesting stuff. And I just wonder, was there anything that has sort of really surprised you, that, you found that's, that it's resolved with dietary changes, within either personally or your personal relationships or within your patients that is something that you would have thought maybe wasn't a dietary problem?
Not really, Sean. I think what I try and explain to a lot of my patients and family and friends is that we've got an amazing bit of kit. I think the human body is a stunning bit of evolutionary genius. There's obviously people that are born with genetic defects and chromosomal issues, and that's no fault of their own. These are mistakes of nature in terms of their damage to their DNA, and that's not their fault. But vast majority of illness that we see is just this terrible food environment in which we live with extremely sedentary lifestyles, right? So I have not seen an issue that a good diet and a little bit of resistance training can't correct. So we can become very one-eyed in this space because you think diet fixes everything, but largely speaking, it really does, doesn't it? With chronic illness, 99% of it will resolve with the right approach.
Yeah, I think effectively we could put ourselves out of business.
Yeah, we could.
We could probably put 90% of the physicians out of business. We don't, obviously you still need the trauma and the birth care and the infectious disease stuff, but
of course,
beyond that, a lot of this chronic disease would probably be, much less prevalent than it is. Proton, this has been wonderful. Again, thank you. We've gone through an hour. I want to be respectful of your time. And like I said, if you guys aren't following him on Instagram, he's putting out a lot of really good studies, and I think it's a very, very good stuff you're doing out there. And so let people know where to find you, social media, if they want to book an appointment with you, and if they're, I assume, local to Australia, how do they do that? And anyway, thank you again.
Thanks a lot, Sean. Thanks for having me. I'm pretty active on social media. I just find it Instagram and Facebook good mediums to put out visual content just for people to read. A lot of these studies I read myself and then just kind of summarize it for people in one slide. I'm in Castle Hill in Sydney, Australia, and a lot of people, have been booking in interstate. It's difficult, of course, because we can't perform the procedures. For a lot of these people do need colonoscopies and so forth. So that's limited things to some respect. But what's been brilliant is everyone in Australia can kind of book in to see our dietitians virtually, and that's been great. And so appreciate you having me on, and appreciate the support you've shown me as well, Sean.
Yeah, and just mention your actual social media handle, because people are asking what's the actual number.
Sure, it's Dr._Pran, P-R-A-N _Yoganathan, my last name, and that's on Instagram and Facebook.
Perfect. Okay, well, have a wonderful start to your Tuesday. Are you in clinic, or where are you at right now? Are you?
Yeah, I'm in clinic at the moment. I've got to get changed and get into some work. But thank you again for having me on, and for everyone who's tuned in to have a listen.
Yeah, hopefully. Okay, well, Pran, we'll talk to you down the road, I'm sure. Anyway, good luck, and thanks for doing what you're doing. Appreciate it.
Thanks, mate. Thank you. Take care.
Okay, everybody. Goodbye, everybody. We'll see you guys tomorrow. Take care now. Bye-bye.